Welcome to the Coronary Corner Podcast. My name is Yader Sandoval, your host, and we're pleased to be doing this episode with an invited guest, Dr. Deborah van den Buijs. She's an interventional cardiologist at the Buijs Medical Center, and we're really excited to have her here because she's really been a champion in this initiative of CT-guided PCI, but specifically led a trial on the use of CT in ostial RCA lesions, just recently published. So, Deborah, pleased to have you here. Maybe before we even get started, can you just tell us, who are you, where you work, and how did you get involved with these applications of using CT in this space?
Yes, great. Yader, thank you very much for inviting me to the podcast. Well, I've been working for the last 3 years in the Buijs Medical Center in the Netherlands. And before that, I did my fellowship training, and that was in Hospital Oost-Limburg in Belgium. And that's where I got more involved in CT, and that's where we also conducted the trial, the 3D CT trial. And before that, I was trained as a general cardiologist in Amsterdam. So I only have a short career until now in interventional cardiology. So I'm only, after my training, I've been working for 3 years in Buijs Medical Center. Yeah, and how I got involved with CT is it started already during my general training for cardiology. So in Amsterdam, you do a lot of courses in CT, and then you expand the courses with your own experience. And then when I got to my fellowship, what happened over there is that they already started thinking about doing this trial. Well, yeah, from that trial on, we conducted this study, and then we did more and more with the CT. So that's how I got into CT and also in this trial.
That's perfect. And maybe before we even talk about the trial, it catches my attention that you're saying that during your training, you got exposed to it. So is this something that most fellows get exposed to, back home?
Well, I think during the general cardiology training, you get the option to do CT courses. So to get a degree in how you can judge them and read them. So that's an option. And I think not everyone during their fellowship is being trained to read them and to work with them. But it is an option to do it, yeah.
Now, how do you use CT in your practice now? Is this something that you use CT? I mean, like this is being read by radiologists or cardiac imagers, and if there's a patient coming to your cath lab, you look at the CT to complement that? Or is this being like some of you are reading it also professionally as well, doing the read and then doing the case? How is that being used in your practice?
Yeah. Well, currently it's not as much as I would like, but we are planning on to expand that in the future. What now really happens is when a patient comes in your outpatient clinic with complaints, you want to exclude coronary artery disease, we do the CT scan. But if there is coronary artery disease, normally now, if there's a high calcium burden, it stops. There's no contrast being given, that's it. But I think that in some cases would be very useful to do it, because if there is a high calcium burden, you can really use the CT to have a look at the coronary artery, the anatomy, how everything is situated. So we're hoping to expand that. Furthermore, if there's a CT and I get a patient into my cath lab, I will have a look at the CT, especially when there's contrast being given. So I'm having a look at the anatomy and I'm scrolling with the 3D images through it, how the anatomy looks and how much calcium burden there is. So that's how I use it right now. And following my own experience also with the study, especially in significant different lesions, difficult lesions, I'm having more better look at the CT with imaging to see how the lesion is. So that's how I use it right now.
That's wonderful. And you have the post-processing software, you have access to the CT software in the cath lab?
No, we don't have it in the cath lab. It has to be done on forehand. We also have radiologists and cardiologists have a look at the CT. And the post-processing, we currently use the Dimensio imaging technique. So that's what we do, but we don't have anything more than that right now.
Okay, wonderful. Well, so again, there's this very exciting study. Again, congratulations on the use of three-dimensional CT for ostial RCAs in circular interventions. Tell us, I guess, maybe just to get started, what led to this question? What was the rationale background to lead to this trial?
Yeah. Thank you. Yeah, what we noticed, and especially the cardiologists that were working in Belgium at that moment, is when they got a patient that previously had a PCI of an ostial RCA, when they got them back into the cath lab, it was very difficult to have a clear anatomy of the lesion and also the stent that was placed before. And they had really trouble finding the correct angle of the C-arm to have a good view at the ostial plane. So that's why they started thinking, well, we could do this better because we're using pre-planning with the C-arm with the angles in TAVR and in the mitral valves. So why not use it for these indications? So that's why they started thinking about that, and then they contacted a business model. It was materialized, and they made 3D models. So they contacted them, and they had a look together. How can we visualize the orthosteal plane correctly to have a good C-arm angle before you start a procedure? And we were thinking that might prevent more contrast use, more radiation use, because when you don't use it, you have to look at what is the correct C-arm angle. You give a lot of contrast, and eventually you hope you have the good view. So that's how we started to think that this might be a good solution.
Perfect. So it seems like a lot of the thought was mostly on the optimal angulation. Was there thought also about, the plaque features, calcium at the ostium? What was the thought? What were you guys looking at with respect to plaque characterization?
Yeah. So especially in the ostial RCA lesions, there's difficult anatomy. So the lesions over there are notoriously challenging. So what you see is sometimes a lot of calcium burden, but also there's a tendency to recoil because of the musculature structure. And especially when there's a lot of calcium at the ostium, it's very difficult to really have a good look with 2D imaging with your angio, how the anatomy is. Does it have a high takeoff angle, or does it have another anatomy? So that's also what we have had a look at with the CT. So how much extent there is of calcium, how many plaque burden there is. So you can also plan your procedure with, maybe I need more calcium modification. So you can start by pre-planning your procedure, not only for the C-arm angle with your viewing angle, but also to plan your procedure, what to expect.
Okay. And tell us a little bit more. So these were mostly like outpatient elective procedures with stable angina that had a CT beforehand. That was sort of the population, correct?
Some of them were. So some procedures we already had the CT and then they came into the cath lab. But also we had some patients that came into the cath lab with complaints. So we had a suggestion of angina. And then we noticed the ostial RCA lesion. So then, because they were stable patients, we took them out of the cath lab. We did a CT in the next 2 weeks. And then we analyzed those ones. And then we got them back into the cath lab.
Interesting. You were saying that the software that here, was it 3Mensio exclusively what was used for the analysis, or what sort of applications did you do to perform this planning?
Yeah. So the application was designed by Materialize. It is a company in Belgium. They are trained in 3D modeling. And what they did is had a look at how you can correctly put your orthosteal plane in good view. So what they did, they made some planes through the ostium of the RCA. So they did a sagittal plane and a cross-sectional plane. And then they put a lot of dots on those planes. And then they had a look with those dots if they would cross. So if those two planes would cross, that would be the correct angle. If they couldn't find a cross-sectional of those two planes, then they did another axial. So it was cross-sectional to the previous one. They also drew all of those dots, the S-curves on it. And then they also checked if those crossed the previous one, and then they got the optimal viewing angle. So that was the software they used. But what we did in the study is we checked if the Trimensio, for instance, that was the software almost everybody uses, if that was also the same with the Materialize analysis, and that showed a good correlation.
And the one from not the 3Mensio, the material, is that automated? I guess when you say when it crosses in the two planes, is that sort of like an automated, intended to be an automated process that the angle will be provided to you, or do you anticipate that this will be a manual process that the reader or the interventional cardiologist needs to provide an input for that angle?
At that moment, it was done manually. So what they did was the planes that were drawn through the ostium of the RCA, those were done manually at that moment. But I think it's also, well, possible to do it automated. So it can, well, just one click and you have the optimal viewing angle. That would be, well, the preferable one. Yeah.
And for the cases, so you have a case with an ostial, right? You're about to enter the case. You've done the CT. You have the angle. What were there any particular components of pieces of information that were being provided to the interventional cardiologist beyond the optimal angulation? We talked a little bit about a plaque, but was there any specific information that was being provided, like vessel size or other elements to guide the procedure?
Yeah, there was. So what we also got was the MLA that was provided to us. We also got the calcium burden, so more of the angle of the calcium burden. And we also got the diameter of the vessel. So those were the three extra options we also were given. So that was also very important for us to plan the procedure, to expect maybe what kind of stent we needed. Do we need more calcium modification? So those three extras we were also given.
Okay. And tell us a little bit more, maybe more about your primary endpoint. How did you decide that this was the important endpoint to look at, and what did you find?
Yeah. So what we did, we conducted in a single center randomized control trial, a total of 30 patients, with 15 patients randomized to angiography guided PCI. So the interventional cardiologist was able to have a look at the correct C-arm angle. And then the other 15 patients, those were randomized to the 3D CT PCI. So we got the angle before. And then what we had a look at with the study was the first primary endpoint was geographic miss. So we had a look at the stent placement if the true ostium was missed. So the stent was placed too distally. And then with the proximal stent strut being in outside of the first 3 millimeters of the ostium, or the stent was placed too proximally. So there was a protruding stent of more than 3 millimeters in the aorta. So that was suggested as geographical miss. So that was the primary endpoint. And secondary, we had the percentage of patients that needed an extra stent. So when the ostium was missed for more than 3 millimeters, then we placed an extra stent. And we also had a look at contrast dose, radiation dose, and the procedure time. Those were the secondary endpoints. And as an extra, we also compared the calcium RBMLA and the vessel diameter with IVUS. So the measurements we got from the CT, we compared that with our IVUS measurements.
And what did you find? Did it work?
Well, it's a pilot trial, so we couldn't power it for hard clinical outcomes. But what we noticed is in the 15 patients that were randomized to the 3D CT trial, when you have a look at the 3 millimeter miss of the ostium, none of the patients, the ostium was missed. So we got a correct stent placement in all 15 patients. But if you had a look at the angiography guided patients, there were 2 patients that missed the ostium, and both of them had the stent placement too distally. And in one patient, there was an extra stent needed. So there was like 5 millimeters of stent of ostium missing. So an extra stent was placed in that patient. There was no significance. The p-value was 0.06. But what we also did was a post hoc analysis afterwards, where we put the geographical miss at 1 millimeter. And what we saw that then it became significantly in the 3D CT arm. So with a p-value of 0.03. So that would be better. What we also noticed when we had a look at the contrast, we used 50% lesser contrast with the procedures with 3D CT. That was also significant. And what we also find is that we used lesser radiation and the procedure time was shorter in the 3D CT arm.
No, I mean, I think it's a wonderful trial, and clearly a lot of the messages, as you pointed out, it's a pilot, but a lot of the messages align with, I think, this emerging opportunities with CT, that procedural efficiency is enhanced. Oh, you brought the point about IVUS. Was the IVUS? I think this is something that we are. Where this question is coming more and more. This concept of CT guided PCI is emerging. Is IVUS something that you did? I guess in this particular study, mostly for investigational purposes, or was this, I guess, used as a complementary step that you had your whole planning from CT, you knew the angles, you had information about plaque. But were you ultimately choosing the stent size from the IVUS, or how was the IVUS incorporated into the workflow here?
Yes, yeah. So we use the IVUS before stent placement to check the CT. So we got the MLA and the vessel diameter and a calcium arc from the CT, but we wanted to really correlate with the IVUS if the measurements were correct. And we used the IVUS to check how the stent placement was. So to check if there was geographical miss. So that's how we also used this. So we checked if the ostium was missed or the stent was protruding too much. And that's the main things we chose. But we didn't choose the stent from the CT. We used the IVUS because what we also noticed afterwards with the measurements that vessel diameter, because of the scattering of the calcium in most cases, was not really a good correlation with the IVUS. So we chose the stent diameter and also length on the IVUS.
Okay, but that's a good point. You really enhance, as you pointed out, you improve the geographic mismatch, improve procedural efficiency. CT help with that, but still IVUS remain complementary to a lot of decisions, which I think it's an important message. I wanted to ask you, was C-arm, CT and C-arm registration, was that part of the study? I know that that's an emerging concept in this space. Some trials are doing CT co-registration. Is that something that you guys did in this trial? And if not, do you foresee that will be of interest?
We didn't use it in our trial because we didn't have the option to do it. But I think it would be a wonderful solution to have live co-registration, that you have your CT displayed on your screen while you're doing the PCI. And not only for osteal or RCA lesions, but also for other bifurcation lesions or left main. So I think, if you want to, if there's a possibility to have it, I think it would give so much solutions for better PCI. So unfortunately, we didn't have the option.
Wonderful. So what's next? And this was the pilot trial and circuit interventions. What are the next steps in this space for you?
Yeah, so I think it would be interesting to do an outcome trial. So now we used a surrogate endpoint with IVUS, but I think like hard endpoints, myocardial infarction, target lesion failure, I think that's also very important to do. So an outcome trial would be very good, and then powered on this study, and then longer follow-up, I think, because now we did a 6-month follow-up. So I think longer follow-up is needed also in these patients. I think you maybe can also extend this not only to osteal RCA lesions, but also to other bifurcation lesions. So that would also be an option. Currently, there are no definite plans to do another trial, but locally where I work now, there is the ambition to expand the CD guided strategies more widely in the future. But there's no definite plan to extend the pilot trial.
But clearly there's many opportunities, and I guess that maybe brings me to one of the final questions. This has been we've learned so much from your trial and your efforts here. But a lot of our listeners and myself, others, we're trying to use this clinically. What should be the messages for clinical practice? Are there any particular lessons that you feel outside of research we can take and incorporate to day-to-day practice?
Yeah. So geographical miss is very important in these lesions, and the good view at the orthosteal plane is very important. There was a previous study, there was a retrospective study that had a look at different angles, optimal viewing angles for different lesions, and that suggested an LAO 79 and a cranial 41 viewing angle. That is a very extreme angle. We don't really use that often because it also gives a lot of radiation. But what we also thought is nobody is the same. So all of the orthosteal planes are very heterogeneous. And that's also what we saw in our study, that if you had a look at all the patients that had a 3D CT and the optimal viewing angle was chosen, there were a lot of LAO cranial views that were suggested from the CT, but there was a lot of heterogeneity in those viewing angles. So nobody is the same. So that really suggests that a personal T scan would be very very important. But what we also saw is when we compared the viewing angles from the 3D CT with the viewing angles that were chosen by the interventional cardiologists, you see that there were lesser LAO views chosen. So the suggestion would be that more extreme LAO angles can be used. So not only LAO 20, 30, but go to 50, 60. That would be a suggestion from the study. So if you don't have a CT up front, that would be a suggestion to have a look in those angles more. Yeah.
Well, that's wonderful. Well, again, congratulations on this initiative and this trial. I think, the key messages that for me, I think I take here from these conversations are many. But one is that clearly there is an evolving role to using CT in certain complex lesion phenotypes. I think ostial lesions for can be a nightmare for many folks. You have a stents, as you pointed out, protruding into the aorta, or you missed it, and it can become a nightmare. So I think here you're clearly pointing to an opportunity for us to do better for these cases. Same thing for the second message is your point of the angle. I think, we do so much contrast taking all these pictures. Is this better? Is this the other one? And just getting from the CT, you're going to get a reduced contrast, a reduced radiation. And last, I think you point out to the fact that, yes, the CT really enhances the whole preprocedural planning, but that this is a complementary method to a lot of our modern PCI techniques, including intravascular imaging. So again, thank you so much, Deborah, for joining us. And, we look forward to hearing where this goes. And so congratulations and thanks for joining us.
Yes, great. Thank you very much. Yeah, for the invitation. Thank you.